Good evening, and my name is RMason. Welcome to my presentation for NU675. Our first patient is a 45-year-old male who's been married for 15 years with 2 children. He has a history of MDD and pornography addiction, which have both been dealt with through therapy, and furthermore, he's been taking medication for the past 20 years, Celexa. Um, he has also been having some trouble in his marriage, but for the past 5 years, he reports that things have been going well, and he denies having looked at porn. He comes in today, he's visibly upset. He reports that his wife had been cheating on him for 2 years, and he just found out when he came home from work to find a note from his wife. His kids were gone, and it detailed her infidelity and the fact that she took the children to live with her and her new boyfriend, the person she had been cheating with. Divorce proceedings are currently in effect, and he states he had no idea, he didn't know that this had been going on for the past 2 years. He states that he feels so stupid. He's not sure why he bothered to improve himself, and further goes on to say, how can I even go on? He states that his workplace made him take off some time from work, but that's over, and he's now at risk of losing his job because he still is not going in. He states that the kids are his world and that he cannot risk losing his job, but he hasn't talked to his kids for over a month. When questioning him about suicidal or homicidal ideations, he replies that he has been suicidal since she left, and he has been drinking at least a 6-pack at night. He states that he has plans to shoot himself, and when he is asked what is keeping him from acting on those plans, he states his kids, but he also states that he's losing hope that he will ever see them again. So as a clinician, suicide prevention is our top priority, and the patient's expression of having suicidal thoughts needs to be completely explored to evaluate his risk factors and protective factors. According to the suicidal risk assessment from the Minnesota Health Department, identification of risk factors should include identify the risk factors, identify protective factors, conduct suicide inquiry, determine his risk level, and then determine what interventions we're going to take. This patient's risk factors include being a male, closer to middle age, currently in the middle of divorce proceedings, alcohol use of a 6-pack daily, which is a change and an increase from previous behavior, his current mental health disorder of depression, which he has been receiving treatment for, and his addiction to porn. While that is not a true mental health disorder according to the DSM-5, it is still a behavioral impulsivity problem that could present a clue to his ability to control his impulses. This patient needs to be asked about any previous suicidal attempts and a frank discussion on his plans to shoot himself. Does he have access to guns? He is also presenting with a loss of purpose and hopelessness by stating that he doesn't know why he tried to improve himself and he doesn't know how he is going to go on. He is also self-isolating because he is unable to attend work. His protective factors, is this patient willing to be admitted for treatment for suicidal ideation? Does he feel that he is in imminent danger of suicide? We need to explain to this patient our concerns for his safety and ask him about family members who live close by. Would he be willing to allow his family to take possession of his guns? And would he allow me as a clinician to speak with his family about my concerns for his safety? Would he be willing to either go stay with his family, or can his family come stay with him, or at a very minimum check on him daily to see how he's doing? This patient would have to sign a release of information, obviously, for me to be able to speak to his family. We would need to ask him about other protective factors that might help keep him safe. And we should ask him what steps he can take so that he can stay safe. This could include a safety contract that has written steps for the patient as part of his safety plan. It should list who he can contact in an emergency. We should be asking open-ended questions, asking about details, And are there any other safety factors that we could enhance for this patient? At this point, we now need to determine this patient's risk. This patient appears to have multiple risk factors, but some protective factors. He is having suicidal thoughts and he has a plan, but he does not appear to have intent because this crisis has been ongoing for at least a month or more. Hospital admission may be necessary if more protective factors cannot be obtained, such as follow-up with family members and the removal of access to the client's guns. If these two things cannot be completed, the patient should be admitted via a Baker Act per the Florida Baker Act manual. However, if extra support could be obtained, then the patient should start on medication, be given help to develop a safety plan that has written numbers for family support and services such as the clinic number, emergency room numbers, the crisis hotline, 911 and 988, which is a national hotline for safety, and an immediate referral for psychotherapy should be made for him. Medications, if it is determined this patient can have family members who will come check on him, medications that I would consider would include Abilify, because according to Stahl's prescriber's guide, this medication is FDA approved as an adjunct for depression, and it can help improve symptoms as early as 1 week from starting, although it will take several weeks for the full effect. Dosages should start at 10 milligrams PO daily as an augment medication to his current SSRI Celexa. His Celexa should be increased from 20 milligrams to 40 milligrams PO daily. Because the patient has been on this medication for years and the current dose is not controlling the symptoms of depression with these new stressors, it's possible that the medication may need to be changed. However, he has been tolerating it well so far. It may be less stressful to continue this medication he is used to with the addition of the mood stabilizer to help. Finally, safety planning is a series of steps that are designed to reduce the likelihood of suicide. Examples include immediate appointments with a therapist upon release, a callback 1 week after release, identification of warning signs of suicidal thinking, written list of coping strategies that the patient can use for times of high risk, identification of emergency contacts for the patient to have on hand and someone to talk to, emergency resource phone numbers, and the identification of and the removal of access to lethal means. Our second case is a 19-year-old married female with a 2-month-old baby on her 4th visit. Her husband is present with her. She does present today dressed more provocatively than we have ever seen her before. Her makeup is also heavier than usual. The baby is in a carrier and is sleeping. She immediately starts discussing a video series on aliens that she has been watching. Her speech is rapid, loud, and tangential. She makes several looseness of associations between the video series and her baby. From her rambling, it sounds as if she believes the baby is an alien and she needs to take it to the desert to leave it in the mountain for the aliens to come and retrieve. She reports making plans to go camping with the baby and her husband this weekend. We question her about suicidal and homicidal ideations, and she denies both. The husband states that she has been acting different for a couple of weeks, and she has never behaved like this before. He is scared to leave her alone with the baby. She interjects that she knows the secret to world peace, and giving their baby back to the aliens will accomplish it. The first and foremost important step in this case is to work towards the safety of the child. While the father is currently in the room, it needs to be explained to him that the child is at risk with the mother. While it may not seem fair to the father who is attempting to do the right thing, and he is currently with the mother and the baby, according to the mandatory reporting laws in Florida for a healthcare worker, just the threat of the mother leaving the child alone in the desert is enough to warrant a call to Child Protective Services. Child Protective Services will be able to follow up on the case because after this visit, the parents may never come back to our office. It may be impossible for us to follow up. So it has to be turned over to Child Protective Services. As far as the mother goes, the DSM-5 states that the psychotic features or delusions can occur at any point during depressive episodes. It also states that almost 50% of postpartum depressive disorders start before birth or within 4 weeks of giving birth. While infanticide is a rare occurrence, it is most often associated with psychotic episodes that are characterized by command hallucinations to kill the infant or that the infant is possessed. In this case, the client is reporting the infant as an alien and that she needs to leave him in the desert. According to Elizabeth Brown, a news reporter, after giving birth, stress and anxiety go into overdrive, and that can lead women to a distorted perception of reality. While it is uncommon with statistics showing 1 or 2 cases for every 1,000 births, in the United States alone, we have 3.8 million births a year, making the number of possible infanticide cases anywhere from 4,000 to 8,000 cases per year. This is not a low number. My first steps with the mother would be to attempt to collect further history, such as a history of bipolar disorder, previous depression, or anxiety diagnoses. I would ask her if she has taken any drugs or supplements, and I would perform a complete medication reconciliation to ascertain if any of her medications or supplements might be causing this psychosis. I would also ask her about drinking behaviors or previous psychotic episodes. I would ask the mother if she is willing to be admitted to an inpatient center for psychiatric help to help her with some of the beliefs she is currently experiencing, and explain that to her and her husband that I am very concerned about her safety and for the safety of the baby. I would ask about family members who might be able to come and stay with the family for the next few weeks, or if the father is going to be able to take time off of work to make sure that the baby is not left alone with the mother, even for a few minutes until she is no longer psychotic. I would go on to explain that she has a very treatable condition, that it is a malfunction of the neurotransmitters in her brain that has possibly been unbalanced by the hormones and stress of giving birth, but with medications and therapy is very likely to improve. Sadly, because this patient is denying suicidal thoughts and she denies homicidal thoughts, she is not threatening to kill her baby. She does not qualify for a Baker Act in Florida. Although I would strongly encourage her to consider inpatient help for her psychosis so that medication could be started right away to help her. If she did not agree to inpatient therapy, I would start her on Zyprexa, which is a second generation antipsychotic medication and also a mood stabilizer. According to Stahl's Prescriber's Guide, it is often given for many mental health disorders that include psychosis and impulse problems, such as schizophrenia and mania seen in bipolar. Specific questions about breastfeeding should be asked, as most recommendations are to discontinue breastfeeding, as there are reports of excessive sedation, irritability, and poor feeding in the child. However, Stahls does report that women who choose to continue breastfeeding should have the child monitored for adverse effects. So it is possible for her to take this medication and continue breastfeeding if she chooses, although not recommended, and that does need to be explained to her. That would definitely be my treatment plan for this patient. Thank you very much.